Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. I'm with Ian and Tim, and today we are going to go over diagnosis of the acute abdomen. How are you guys doing?
Almost excellent.
Outstanding. So let's just jump into it. When you're dealing with trauma, I think things are a lot very straightforward as far as one, visually seeing the trauma, two, doing a EFAST exam or something similar, blood, TXA, abdominal dressings. We're definitely trained in that, but things are not always as straightforward. When somebody's coming to you like, I have very diffuse abdominal pain, it hurts on the right side, it hurts on the left side. It's been hurting for a few hours. How do you go about, figuring out, if this is a medical issue that you can deal with? Is this a surgical issue that's just starting to brew? How do you go about doing this?
So I think what we both do, I think what most emergency physicians do is, the first thing we always do is we want to know what are the vital signs and what does the patient look like, because at least that gives us an idea of the severity. If they look pretty comfortable, then already I'm thinking, this is less likely surgical, or even if it is, we've got some time to sort it out. So that's what I always start with, whether it's in the hospital or outside of the hospital.
And so the key thing is the vital signs being vital, right? So if they're tachycardic and they're febrile, that leads you down to a whole different kind of differential than if there's someone that's sitting there with stable cold vital signs, afebrile. And then again, so what does the patient look like? Are they just laying there and playing with stuff, looking around, or are they sitting really, really still and they don't want to move because it hurts too much to move, or are they writhing all over the place? So it gives you a better idea, the severity and the urgency of your patient. Okay.
Now, is that, usually when people, first come in, you have your initial impression. Is this somebody that you're going to kind of observe over a little bit of period of time while you're dealing with other patients to see if that changes, or that pain is, cyclic, or is it consistent?
No, yeah, definitely. You'll be watching them over time. But I think that first appearance gives us the best idea of the severity right up front as much as anything. And then, then after that, then, they always talk about history is 80% of your diagnosis. And with the abdomen, if you're going to make a diagnosis, it really is a big percentage of it also. The first things I take into consideration is the patient's age, because that gives me a whole different set of differentials, right? Somebody that's over 65, much higher likelihood of having a surgical process going on. Somebody that's 20 and young and healthy, much less likely. And their past medical history, past surgical history, the meds they're on. So all of those are really gonna kind of help me shift which direction my differential is going to go. And then, like you mentioned, Dennis, when we talk about pain, we always want to know all the things about pain. What's it like? Where does it go? Does it radiate? When did it come on? What makes it better? What makes it worse? All those things kind of help me look into the bucket of the differential diagnosis I'm going to start working on.
So the abdomen is that big black box. Unlike other parts of the anatomy, you can see. You can't see past the skin. So I agree with Ian on that. A lot of times it's depending on the age groups, the elderly folks are much more susceptible to surgical diseases. The younger folks, not quite so much, because you're only going to one or two different on the things on the differential. Really, it's interesting to see how their description of the pain. So I had one young lady today who had a sudden onset right lower quadrant pain. And she's also having this really rigid abdomen. She doesn't want to move. Oh, and by the way, my right shoulder hurts. So that tells me a whole lot right there of where this pain is coming from and whether or not it's going to be a surgical emergency. So, that description of the pain, it's a really sharp pain. I can't move. It hurts every time I move. I take a deep breath. Oh, and by the way, for some reason, my right shoulder hurts. So that's telling me there's something subdiaphragmatic, something that's irritating the diaphragm that's referring pain to her shoulder. So that tells me it's more than likely it's something surgical. And it was. In that case, she had blood through her entire belly. So it's interesting to see just from that description, you can kind of jump to a kind of set of differentials that you can go from.
Right. Now, obviously, you have ultrasound. So if they have blood in the belly, you'll pick that up with a fast exam. Do you go through a normal abdominal exam? Like, I was taught in the medic course, IAPP, the abdomen. Are there any special tests that you add into that?
I don't know if there's anything special I add into it, but really the biggest thing I'm looking for in an exam, one, location, because that helps with my differential. But then the thing that really tells me if this is surgical or not is if there's peritoneal signs. And for me, peritoneal signs is some sort of involuntary guarding, whether that's percussion tenderness, cough tenderness, heel tap, one of those.
Okay.
If somebody has peritoneal signs, then that pretty much says that it's a surgical process, and they're gonna need to have surgery involved. So, I do. I listen to the abdomen, I inspect the abdomen, I palpate it. But the biggest thing I'm looking for right away are there peritoneal signs or not.
Yeah, and that's I think the biggest indicator for emergency of your situation. And how soon do you need to get that the surgical consult or evacuation done? If there's no peritoneal signs, you got time. If there's peritoneal signs, more likely they're going to require some type of cold steel. I agree with Ian. Location. There were very different parts of the abdomen, the left upper quadrant, right upper quadrant, left lower quadrant, right lower quadrant, have very specific parts of the organ systems there. Where you have your typical disease processes. So as long as you know the anatomy and know what's there, and then you can kind of define it using your normal kind of examination techniques, it'll give you a better idea of exactly what you have going on.
Right. And I imagine with the history and locations of the pain and just your knowledge of what lies underneath where that pain is, you can probably narrow things down quite a bit.
Yeah. And then also can drive imaging. So it's easier in the ER where, I can throw them in a CT scanner and get a look inside the belly. Not so easy, like we talked before. I work on ships quite often. So not so easy when I have no imaging on a ship and all I have is an ultrasound. But ultrasound goes a long way. You can see a lot of things that you need to see with an ultrasound. And whether or not something that, is an emergent life threat or non-emergent life threat. You can rule out a lot of things as well.
So you mentioned the last podcast, an evac might be 2 or 3 days from one side of the strait to the other. How are you making that decision with very limited imagery and just your history, just your physical exam? How are you making that decision whether to spin that boat around or to hold on to them medically?
You do as much as you can to define your differential, right? So if I get down my differential and I kind of check off things as I'm going down, okay, it's not anything left lower quadrant, so it's not something doing with the bowel. They're afebrile, they're not tachycardic, so probably not a diverticulitis. Right lower quadrant's okay. They don't have an appendicitis because they have no pain there or have had a prior appendectomy. You see a scar there that tells you, okay, they've had their appendix out. We're good. So you start checking those things off your differential. Have a very broad differential to start checking them off. And if you get down to, something where my choices are either they have an acute cholecystitis, a really bad gallbladder, or they're having some type of cardiac issue. Either one of those is nothing I can do about it. So that's something that requires us to, kind of turn around and evac them as expeditiously as possible.
If you had to think of 2 or 3 things that you lean very hard on when you're dealing with somebody who's coming in with abdominal pain, what are the 2 or 3 things that you really rely on?
So I would say, like I mentioned before, for the exam, parrot and yield signs. I mean, that makes a yes or no question right there. But then if you're saying if other things you lean on, we actually talk about this a lot in wilderness medicine. The one lab that we always want to have with us in a situation like this is an HCG, a urine HCG, because that it's the one lab that can actually make a definitive difference on need an evac versus don't necessarily need an evac with a childbearing age female.
Yeah. And I agree. I'm a big, vital signs and physical exam. The exam will tell you 99% of the time, and you're going to get the rest of it from the history. A lot of times we'll diagnose an appendicitis. We'll say, this is pretty much a standard appendicitis. We'll still get the imaging, but a lot of times I'll call a surgeon and say, okay, this guy's got a classic exam, tender's the right place, he's febrile, he's got an appendicitis, it's time to take his appendix out. So even you don't need all the bells and whistles, except when you start getting into the elderly. then it becomes much more difficult. So,
right. Just out of curiosity, with CT scans and MRIs and things like that, when you're an experienced provider, how frequently does that imaging really change what your initial diagnosis was?
Depends on the age of the patient.
Exactly. Yeah.
The younger they are, the less it changes it.
Okay.
Yeah, and I would agree. I can typically tell with someone under 50, I can typically tell you exactly what their disease is before we get the scan. And that's where you kind of want, you're going to, based on, like I said, again, physical exam findings, history, you can narrow down your differential pretty quickly to one or two things. But when you get into the, extremes of age, the younger ones that can't talk to you and the older ones that either can't talk to you or can't remember what they said to you, you're talking entirely differential. You're talking either 90 years of stuff that they've had building over time. So you never know exactly sure what's going on in that box.
Right. Well, outstanding. Hey guys, is there anything else that you would like to add with acute abdomen?
Probably the only thing I'd add is, what are we gonna, if we're in a more prolonged field care situation, what are we going to do with these guys? As soon as we've decided it's surgical, they're going to get an antibiotic. They're going to get some pain control to make them comfortable, and then we're going to start working on the evacuation. But if it's surgical, then I can't think offhand of situations where I wouldn't give them an antibiotic.
Right. And I would agree. There seems to be a lean now towards actually antibiotic treatment of appendicitis and cholecystitis. As long as they're hemodynamically stable, you're seeing more and more leaning towards just using antibiotics itself. So you can do a lot by making sure you apply that on an antibiotic to stabilize that person.
So antibiotics are just like ertapenem. Would you add something like Flagyl? Yeah.
It'll kind of depend on what do you think's going on. But ertapenem is going to be good for a lot of them. Unison's going to be good for almost everything that you're dealing with in the abdomen. So it'll sort of depend on what you have, but typically we're going to want something that covers gram negatives and anaerobes. Okay. In some manner, shape, or form.
Yeah, and the Flagyl will give you, metronidazole Flagyl will give you some additional coverage as well. So.
Okay. All right, very good. Well, thank you, guys.
Well, thank you. Appreciate it.
All right.
Thanks, Dennis.
Yeah.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.